Hi, everyone. Good morning. As David just mentioned, I am on the side of decision making. So my formal training is in industrial engineering, where I develop decision models using mathematics, probability to figure out the best pathway, the treatment options, interventions, things of that sort. So today I'm going to present an overview of this decision science approach or decision theory. It goes by a lot of different names. System science is also a different name that you might hear. So just to give kind of like an overview of what decision science means, this is going to be the study of how people and organizations make choices under uncertainty. So really, we're interested in how do you make a decision now based on the fact that you don't know what's going to happen in the future. So we look at a lot of different probabilities and we figure out, well, if this one thing happens, this is how the patient may react. This is the expected survivability, or this is the expected quality of life. Would we make that decision? So that's essentially what we do in decision-making spaces. We use data. Modeling is a big part of this, behavioral insights as well to improve outcomes. So the goal is usually to have an objective function of maximizing health outcomes or minimizing complications or even minimizing costs. And you may even hear of people doing cost effectiveness, which I'll also talk about a little bit, where you have an impact of some sort, maybe a health outcome, but then you also have costs that you're considering. So you have to kind of weigh the trade-offs between the two. So there are four main components that I'll talk about when it comes to decision science. There's the modeling and analytics. This is the mathematical model. This is like the framework that we would use. You can use simulation, optimization. Optimization just means that we're trying to reach the best possible outcome. We have these behavioral insights. So this is going to take decision theory, heuristics, psychology. How do people interpret these decisions? And what is the evaluation of behavior and how that plays a part in the decision? We have data and evidence. We can't build these models without statistics, without the machine learning, which I've heard about over the last couple of days. We have causal inference here. You may also use AI to some extent. But we need the data to support the mathematical model. And then hopefully eventually we get to the point of policy and implementation. And we're able to not just take these models as an academic exercise, but try to figure out how we can actually implement them in an optimal way. So I want to present this one paper that we kind of started working with to kind of figure out what was the decision before, how have people imagined this? And this paper is around managing solitary pulmonary nodules. And there exists a trade-off. And I think we've kind of talked about this this morning, even over the last couple of days, is how do you know when to make a decision now versus waiting? And what is the impact of waiting? If something is so impactful that you have the evidence to move immediately, why would you wait? These are the type of questions that come about. So with this trade-off, you have these potentially curable malignancies. So these should be resected without delay. Then you also have benign nodules. So you want to avoid the risk of surgery and invasive procedures as much as possible. The decision in this particular model is immediate surgery, biopsy, or observation. And the outcomes that they were interested in are the comparison of life expectancies of patients managed by the different approaches of these solitary nodules. So I'll give you an overview of what this looks like. This is a decision tree that can be used. As I mentioned before, you can use simulation, you can use optimization, you can use any different type of modeling frameworks. I also use Markov decision modeling as well. But this decision tree is a nice way of formulating the problem, and how it's usually solved is that you build the tree going forward and you solve it going backwards. So what we have here is the decision between immediate surgery, biopsy, or taking an observation. They also have these subtrees, which are pretty small to see, but the first one is the surgery tree. So essentially we're trying to see what happens if you decide that you go to surgery, the cancer is found, it's resectable, and then you have these different outcomes of interest. So they have this first surgery tree. Then they have another subtree, which is this biopsy subtree. So then you have these different outcomes, and I apologize in advance how small this is, but trust me, these are just like the outcomes that they predicted could happen if you do a biopsy. The outcomes of interest kind of link you to other subtrees, and then you also have outcomes. For this particular model, they were interested in survivability. So one of the main outcomes is death, and of course, survival. The last tree is this observation tree, and that's the last subtree, which is this called wait and watch subtree. They have the outcome of death, and then they have some other subtrees that you might see. If you're waiting, you might see something that means that you need to move to surgery. So now you move yourself to the decision tree that's reflected with surgery. So this tree or these subtrees kind of come together and make this really massive decision tree. And as I mentioned, you kind of work backwards in terms of evaluating the best outcome. So if our objective is to improve survival, then we're going to take the maximum amount of life years that you would see based on these decisions. So we take the expected value as a combination of expected life years as well as the probability of that branch being correct, and we take the maximum value, and then we work backwards to figure out what would have been the best decision for different cases. So the results of this particular model here is one of the tables from the paper, and it just shows you for different scenarios. We have different ages of patient characteristics. We have the estimated probability of malignancy that's a part of the model. This is one of the parameters. These are the different options that you have in terms of decisions. You had observation, biopsy, then observation, biopsy, and surgery, or immediate surgery. And this just gives you the average life expectancy that are produced based on those different strategies. And from here, someone may look at this, and understand what is my expected life expectancy based on this mathematical model. I wanted to present, hopefully fairly quickly, this other model that uses a decision, an economic decision analysis model for screening for lung cancer, which I think is pretty relevant. So basically, the trade-off here is that you want to make sure that we know that screening is impactful. It has a major impact on survivability, but their question was, when is it cost effective? So you have this screening versus no screening, and they wanted to compare survival and cost for patients who have annual lung cancer screenings as opposed to no screening. And their decision tree is here, where you have this, and they were doing this in a high-risk patient cohort population. So you can screen versus no screen, then you have these subsequent actions that can take place. When you screen, it can be positive or negative, and then you follow up with the appropriate actions. And then at the end, you kind of see the survival as well as any indication of cost. Their main outcome was cost. So now we have two different outcomes. We have life years and we have cost, life years being on the top, cost on the bottom. The solid line represents those who did not screen, and then the non-shaded is those who did screen. So you see that it's elevated in terms of life years, and they did this for 5 years out. And then the bottom, you also see the cost. So this becomes the trade-off between life years and cost, and that's why this is a cost effectiveness model. So lastly, I want to talk about some current work that we're working on, and this is like a reimagined decision tree. So we're taking the information that came from that very first decision tree that I showed you, that was from the 80s, and we're trying to update the probabilities based on what we see in current practice. We want to also adjust, we have been adjusting the branches to reflect current practice as well. And then we also want to add in this expansion of that observation branch, this wait and see or wait and watch branch, to consider the size of nodules that you may see: slow growing, moderate growing, fast growing. And we can also look at the different outcomes. So the very first tree we looked at from Cummings looked at survival. The second tree we looked at cost. So we can look at different outcomes, whether it's survival, utilities. And when I say utilities, I'm talking about some type of evaluation on life. It could be the quality adjusted life years you may have heard before, but then also we can consider cost. So this is a brief overview of decision science and kind of where we have been, the different structures that we have seen, as well as where we could go. And hopefully we'll get to the answer of the thresholds in which you know to just move to surgery versus waiting. So that is all I have this morning, and thank you again.